Dahawi to present the first speaker, Professor Bin Zhu. Thank you.
Thank you, Professor Lakhdar. Good morning in some places, good evening in other places, and good evening, Professor Bingsu. I have the pleasure and the honor to present Professor Bingsu, who is Professor of Neurosurgery in Hushuan Hospital. I hope that I say it correctly, in Fudan University in Shanghai. He's honorary Vice Chairman of JUA International Neurosurgery Center in Zhengzhou, and executive member of the ASEAN Congress of Neurosurgeons, and also co-chair of Education Committee at the Australian ASEAN Neurosurgical Society. Since 2005, he is full professor in Division of Cerebrovascular Surgery and Interventional Neuroradiology in Shanghai, China. He was trained by two big names in vascular neurosurgery, Jack Morey and Joan Nesiami, and he is definitely interested in surgical and interventional treatment of cerebral and spinal vascular diseases, including aneurysm, EVM, and cavernomas, moya diseases. Many awards was given to Professor Bingsu in China, and I want to thank him for being with us for the Morocco webinar series. And Professor Bingsu, will you please share your screen and share your slides? Thank you.
Okay, thank you. Dear colleagues, so my topic is the simplest STA-MCA bypass. I have visited Morocco for 3 times. I have very good memories in this great country. And STA-MCA bypass is an end-to-side anastomosis. So it's most adopted blood flow augmentation procedure. So the indications included complex aneurysms, moya vasculopathy, and sometimes we used in school-based malignant tumor involving the wall of ICA, such as a nasopharyngeal carcinoma. So when they want to remove the carcinoma totally, sometimes they have to sacrifice ICA. So before sacrificing the ICA, we will do the bypass. So how much blood flow can the STA-MCA supply? You can see this is a follow-up, long-term follow-up after STA-MCA bypass in moya case. So we can see the STA feeded all the whole hemisphere, even the contralateral frontal lobe. So you can see after the revascularization for the moya vasculopathy, like this patient, the whole brain was the blood flow was replaced by the ECA branches. So STA-MCA bypass is also very important in treating the complex aneurysms in ICA aneurysm. Before the STA-MCA bypass, we should estimate the natural collateral blood flow, guarantee enough blood flow replacement. So from no bypass to STA-MCA double bypass to radial artery bypass to STA combined with the radial artery bypass, even saphenous vein. So like this patient, this is a extracranial ICA giant aneurysm. Before the bypass, the radiologist, they tried to use a fluid diverter, but it's failed. So this is a pre-operative estimate. There's only little collateral blood flow from ACOM and PCOM. So I treated, I used STA-MCA double bypass, combined the progressive clip. I designed this clip And you can see after the surgery, at the first stage, I narrowing the ICA around 70%. Then in the next 6 days, achieve the totally occlusive ICA. So after 7 days, we redo the angiogram, and we can see the double bypass was all patent, and the MCA was territory was fed by the STA. So the ICA flow was totally replaced by STA and ACOM and PCOM. So normally the STA MCA double bypass is enough, can achieve enough flow replacement for M1 to M3 aneurysms. So this is a MCA aneurysm. You can see the double bypass. The STA replaced the whole MCA territory. For the Moyamoya case, I normally use STA MCA bypass combined EDMS. So the skin incision, bone flap, dural was all designed, individualized. So we try to use all the 3 branches of ACA, which is STA or post-auricular artery or occipital artery of the scalp, anterior and the posterior deep temporal artery of temporal muscle, and the middle meningeal artery of dural. So after the combined approach of Moyamoya, we can see all the 3 layers arteries. The STA MCA was patent, and all the spontaneous stoma grows very abundantly. So the stoma located in ischemic area. So after the intraoperatively, we can use flow 800 to check the blood flow in the bypass. Normally, we can find the red T sign, which means big difference of delta P. So this kind of bypass is sustainable. So on the left side, this is a single bypass. On right side, it's a double bypass. So this is a long-term DSA result. We can see the blood flow was replaced by some of the ICA blood flow was replaced by the ECA branches. So bypass technique is not a dying art. The ischemic brain can be revascularized. The simplest bypass technique is easy to learn by residents. So a bypass surgery is like a mountain ultra trail running. It needs a balance, coordination, speed, concentration, agility, patience, flexibility, and perfectionism. So how can a resident hike his mountain? We can use 3 steps. The first step is modeling training. Sometimes we can use plastic graft sutures, the silicone models, the plastic balloons, chicken wings, and the placenta vessels to train the bypass technique. And this is, I performed the anastomose on rats. So this is a live model training. Normally we use a rat to do the bypass training. So the third step is a high flow central exposure. So this is Dr. Frastiani from Italy. She followed me for 2 months. So I showed her more than around almost 200 cases in 2 months. So after I come back to Italy, she already performed 12 STA-MCA bypass, 100 patency rate. So last month, she performed the 3 bypasses. The mean occlusion time is 23 minutes. So it's a very good record. You can see this is her work. After 5 months follow-up, you can see the STA enlarged a lot and the blood flow was very abundant. So this is my personal experience in bypass. My personal record is 5 minutes, 40 seconds to finish a stoma. 13 cases in 5 operating rooms in 1 day. Last year, I have more than 1,000 cases. Now, totally, I have more than 7,000 cases in China and India. So actually, the bypass technique was quite easy. For most of this kind of patients, they already existed the ischemic condition, so time is very important. If you use the traditional STA-MCA bypass, normally it would take more than 20 minutes, even in a very skillful bypass neurosurgeon. If you use the simplest bypass technique, normally it can need the less time. So my mean occlusion time in more than 7,000 cases, it's around 13.5 minutes. So after the first successful bypass, the second one can be used for hands-on training for the assistants. So my assistant, the first 10 bypasses was all trained in this way. So you can see the first one was performed by myself, and the second one was performed by my assistant. So the dissecting STA or post-auricular artery or occipital artery, I always dissect it from inner side of the scalp, use a very low power monopole. So it's quite safe and fast. Only take minutes. And after harvest the STA, I close the incision of superficial temporal fissure like this way. So normally the 2 layers situation, including galley and superficial temporal fissure. So if the sarcose is quite wide, I will fix it with a dural strip. So after this treatment, the delayed scalp healing or infection of scalp never happened. So the simplest anastomosis means I only use 2 or 3 curved microtemporal clips. Don't need to sacrifice any branches of the recipient artery, and no rubber mat or silicone rubber tube is needed. I always use interrupted suturing. Square knot is enough. So square knot is also called the sailor's knot. It couldn't be loose. So the square knot, you should pay attention to the direction of the suture tear. The suture tear should point to reverse direction. If the suture tear point to the same direction, actually you made this slide knot. So the stoma should keep the oval shape as natural branches. You may notice that all the natural branches, it's oval shape. Actually, we can calculate the resistance coefficient zeta. Some neurosurgeon would have recommended the fish mouth stoma. If the donor artery was quite small, you can use this fish mouth stoma. But if the donor artery was bigger than the recipient artery, actually the fish mouth stoma can make the zeta more greater. So if you use oval-shaped stoma, you can calculate the zeta. So under the same condition, the ratio of A3 to A1 is closer to 1. So the local zeta is smaller comparing to the fish mouth, and the local energy consumption is lower. So there's lower rate to form the stoma and aneurysms. So normally I have one stoma have 12 stitches like clock points. So this is a video for the stoma. You can see the first stitch at the toe of the stoma. This is a 10-0 proline suture. So the suture tear always point to the reverse direction. So in less than 6 minutes, the stoma was finished. So this is after the suturing. You can see all the branches of the recipient artery was kept intact and never sacrifice any small branches. And actually, sometimes I left a tiny perforator of the recipient artery open to reflux. So with the help of the small reflux blood flow, it can keep the small pressure in the recipient artery. So it can make the two layers of the recipient artery more clear, and it's unattached. So it's quite easier, make it easier to do the anastomose. So sometimes we can also use a loop technique to make the movement even less and even faster. So it's still interrupted suturing. This is a real video of the loop technique. Sometimes, if the, especially in the Moyamoya vessels, the recipient artery was very thin, and it's very easy to have a small bleeding from the needle hole. Even sometimes it can tear up for the small hole. So we can use some additional tissue to fix the small holes like this. So make a patch, so tie up like a lotus root. So you can see this is a small fat tissue outside of the stoma to fix the small holes. So we can also calculate the blood flow, how to deliver the blood flow more efficiently. Actually, when the ratio of the donor diameter to recipient diameter is greater than 1.2, so the draining capacity of the recipient vessel is less than the maximum blood flow provided by the donor vessel. So this kind of condition, we can choose stoma near the bifurcation of the recipient artery. So this kind of condition can deliver the blood flow to the cortex more efficiently. Sometimes, especially in the STA, there's some sharp bands. If you cut the sharp bands into a straight one, it can, the local energy loss, HJ, and of the band can be reduced. And on the other hand, the flow can be shortened, and the HF also can be reduced. So we can deliver the blood flow more efficiently through the STA. So the bottleneck of the blood flow, how we can use one single branch to create a double bypass. So it can make the additional blood flow, double barrel to deliver the blood flow more efficiently, like this way. So this is we performed the live case in India, and the Professor Luca Rigli also visited my operating rooms. So this is in Mayo Clinic last year, before the pandemic. We have a bypass course. This is our publications of aneurysm bypass, Moyamoya disease, and last year, this year, we already published this book, and this is my chapter. So this is my typical day. After 10 cases in one day, we still have the time to have a dinner. Thank you. That's all for today.
Thank you so much. Thank you so much, Professor Bing-Su, for this outstanding and amazing presentation, especially inspiring for young neurosurgeon. And you give many ideas and many solutions if you want to learn bypass techniques in vascular neurosurgery. Now we can have a question by the end of the three talks during the discussion session. And now we're gonna move to the second presentation of Professor Luca Rigli, and I invite Professor Houari, Professor Houari Lossif, who is Associate Professor in Neurosurgery. He has had his thesis on SCA-MCA bypass in complex aneurysm and Moyamoya disease, and he's head of neurosurgery department at Al Azhar Clinic in Algiers. He is the assistant editor of the Algerian Journal of Neurosurgery and the general secretary of the Algerian Neurosurgery Society. Please, Professor Houari Lossif, will you introduce Professor Luca Rigli? Thank you.
Yeah, sure. Thank you, Fahd. Thank you all the Moroccan Society and all the attendees for this webinar. So I'm very glad to introduce Luca Rigli, who is a very known, well-known neurosurgeon. So he has done his medical education at Lausanne University. He was lucky to have Nicolas Triboli as a mentor for his residency. Then being a professor at Mayo Clinic, then head of neurosurgical department at Utrecht in Netherlands. So as the first father of microsurgery, Professor Yazagir, Luca Rigli was the head of the Zurich neurosurgical department. So after this few words about his functions, let's talk about his works. Professor Rigli's scientific works. So he had done a lot of research items about stroke and brain metabolism, improving perioperative imaging and improving also microsurgical techniques. he has more than 200 publications and 18 chapters in specialized neurosurgical books. Considered as a worldwide expert he was invited today to give a talk about his huge experience, how to reduce risk in vascular neurosurgery. Thank you, Professor Wigley.
Well, thank you very much for this very nice and kind introduction. I want to also thank the Moroccan Society for inviting me to this seminar, and actually congratulate you also for the efforts putting together such a great webinar series, because I understood that it runs over every week for several months. So this is a great achievement. And obviously, thank you also to Professor El Abadi, Nadia. Thank you for inviting me, as well as Dr. Hassani, the Moroccan Society. I think I have to share my screen, right?
Yes, please.
There we go. Okay. Okay, I think now it should be shared. So yes, the idea was to give a talk about cerebrovascular surgery and strategy to reduce the risks, because that is still the main issue for outcome of our patients. And I seized the opportunity to remind, especially also after such a great talk of Bin about bypasses, that let me just see, make sure that I can advance my slides. Yes. This was probably one of the last meetings in persons we had. That was the Bypass 2020 meeting, which celebrated the 50 years of bypass. And you can see, and I think, Bin, you extremely well illustrated in your talk, bypass is not dead. When I started to do this Bypass 2020 symposium, like anniversary symposium, we thought we would be maybe 50 people, and we ended up being more than 300 persons, and really getting together all the friends and experts, and it was a great opportunity. And we see here in the bottom, we also had Professor Yazargil in a little bit forerunner of the crisis we went through, that he was online in a webinar, and he did his talk over internet. Well, anyway, that was just a short reminder. And Bin, you're here too as well, obviously. So vascular surgery, or cerebrovascular surgery and vascular neurosurgery, really it's about aneurysms, carotids. I am a believer, having been at Mayo Clinic, as you mentioned, I strongly believe that it's about where the vessel goes. So I do carotid endarterectomies, and I think it's a very nice technique. Cerebro-occlusive disease as well, obviously stroke, AVMs, dural AV fistulas, and cavernomas as well. I just had today a talk in Rome. So it's funny, I had a talk in Rabat today and in Rome at the same time. Not the same time, but the same day, was about cavernomas. So how can we reduce the risks? So I'm going to bring you through a little historical view. So this is the entrance to our operating theater. And if we look, this is Professor Cranbull. So this was 1948, and he became a giant of neurosurgery. Essentially there was the nothing in the OR, and a breakthrough was the headlight. And then we go 40 years, or this is Professor Yazargil, still in Zurich. Both were the ORs in Zurich. And you see that there is much more complexity already. So obviously the microscope has a huge breakthrough. But if you think about it, also the headlight and the microscope, it's about visualization. So we have to see the structures so that we can preserve them and that we can cherish them and save them. The other thing, obviously bipolar, and there was already a drill at that time. So those were like the breakthroughs. Now, this is what it looks today. We still have the microscope. We have also more than the microscopes, because the microscope, it's becoming a digital instrument today. But we have an ultrasound, we have also neuromonitoring. And if we look at the number of people in the OR, it's huge number of people, just to make sure that we make the safest possible. And The further imaging, we also use the intraoperative MR. So we have intraoperative 3 Tesla MRs and you know, the endoscopes. And I think in the future, it's not going to be obviously about virtual reality, but augmented reality. So the more information we get that can help us to identify what's going on with the patient and what's going on with the situation that we're facing, I mean, I think the more we will make it safe for the patients. So for example, intraoperative imaging, this is the things we use in Zurich. So we have obviously the intraoperative ultrasound. And I think what is extremely important for all of these, it has to be high definition. So the ultrasound has to be high definition. We already mentioned through the microscope also the fluorescence, and it's obviously for cerebrovascular, it's going to be fluorescence angiography. Quantitative blood flow, it's not imaging tissue, but it's getting an imaging of the flow, getting a value on the flow, I think is extremely important, allows you to better understand what's going on in the physiology, allows you also to check the quality of the things and of the bypasses, for example, but also, I mean, we very nicely heard that flow can be extremely complementary. The network of the brain, the collateral flow can be very good, and sometimes the patients do not need bypass. Intraoperative CT is less used for us, obviously in vascular, but it's more for tumors and functional. And intraoperative high field MR, so we have done some studies also about acutely scanning bypass patients, and it's very interesting to also understand better how the flow distributes then in the brain. And for cavernomas and for AVMs, it can be very useful. And intraoperative DSA, I think we already heard also Bin, who mentioned the hybrid ORs for very complex cases. It helps to have this information. So it's not about that you cannot do it without, but if you have the information, if you get the feedback about what we do acutely on while we operate, I think we understand better what we do and the patient can benefit from it. Now, the other thing I already mentioned is the neuromonitoring. And this is a very interesting case. It's very rare that we have such a dramatic change. This was an unruptured aneurysm, but you can see that it's rather irregular. And every time I put on the clip, we would see the neuromonitoring potentials go down. And as soon as we took off the clip, it will come back. And at the end, I mean, this happened maybe once in 5 years. I ended up not being able to clip this aneurysm. And I had to find another solution because the clip, even if I put it further away, the potentials would go down. So again, most of the time you don't need it, but I think we operate more and more asymptomatic lesions, incidental lesions, because they're threatening in the future the patient. So we have to guarantee that the result is not 90%, not 95%, but if close to 99% of our patients have a perfect result. So these are all the things that we can do technologically, technique and computer assisted. Obviously, we can do more than that. And the classic pterional approach, this is what I learned when I started, and it's a perfect craniotomy. Don't get me wrong. I mean, it will never be wrong. I tell all my residents, you should never feel bad that you do a classic pterional, even a little bit larger pterional. If you feel uncomfortable, it will give you access. It will give you all the safety you need to do the procedure. The thing is, though, that we have so good preoperative imaging, we investigate our patients so well today that we know exactly how the anatomy of the lesion is before we go into surgery. So it's not that we are smarter than Yazar Gil or our mentors were, but we have much more information before we go in, so we can reduce the size of the craniotomies. And you all hear about supraorbital, lateral supraorbital, mini pterionals. Well, those are smaller craniotomies, and there is a benefit. There is less skin incision, reduced blood loss, less brain retraction, less brain exposure, shortened operative time, reduced risk of infection, less pain, faster recovery. So there are a lot of advantages, but it should never be with the feeling that you don't feel safe about it. So this, for example, and we also, reported this, these are the 3 mini craniotomies that I like to use for anterior circulation aneurysm. And it all depends on the anatomy, and it has to be studied very carefully. Excuse me. So the incision per se is not the most important thing, but if I do a supraorbital, that means my craniotomy really gets only to the superior temporal line. The lateral supraorbital really is half below and half above the temporal line. And what we in Zurich, what I call mini pterional, the whole craniotomy is below the superior temporal line. So this is how we call it here. So if this incision, well, one junior staff today, he told me, oh, I did a mini pterional, and actually his craniotomy went a little bit above the superior temporal line. Well, that's not a mini pterional in my concept. It doesn't change, and it's very nice anyway. But just so when I call it, this is how I define them. And in a way, the combination of all of these, putting these 3 together, you just have the classic pterional, which again will give you the best exposure if you don't have perfect knowledge of the anatomy before. Because this is very important to understand. If you do a mini pterional and the aneurysm is projecting differently, or maybe it's a very short M1 segment, and depending also how you move the muscle, then you may end up having less good exposure. So it's very important to use these mini invasive approaches very adequately, and understanding how you expose and how you change the exposure by changing the bone work. Now that is what you can do with technology. Those are the approaches. But when I think about reducing the invasiveness of surgery, it's not only about the approach, but it's really about the strategy that we apply. And so if we look at aneurysm, I really think that every time you can do a clip reconstruction, this should be the first option. However, we operate more and more aneurysms that also are complex. Some also have been treated already before. So not unfrequently, the clip reconstruction will not do the whole treatment. And as soon as you have to think about a vessel reconstruction, maybe also using some trapping strategies, well, you have to add some kind of revascularization. Let's call it microanastomosis. It can be an extracranial, intracranial, but it also can be an intracranial revascularization procedure, bypass, which includes the microanastomosis of some vessels. And this is really what I call strategy. So the strategy in definition, if you look up in the dictionary, it's a high-level plan to achieve one or more goals under conditions of uncertainty. And that's really the strategy we do in vascular. And we want to minimize the uncertainty, and definitely minimize that the uncertainty will hurt the patient. And I will use some examples to illustrate what I mean with strategy, and it can be very variable. So this patient, for example, this patient was sent to me from Israel, and he could hardly walk anymore. So he was very, very handicapped. And if you look at this, it's all about understanding the anatomy, and all the complex cases, one really has to spend time, because we have so good preoperative imaging to really understand the anatomy. We should avoid to go in treating these patients if we are not sure what we're going to be facing. So already on the MR, you can see that these are the channels of the aneurysm, or of the still flowing part. So we already know it's going to be a serpentine aneurysm. And the angiogram you know, it's really about understanding that this big aneurysm is beyond the MCA bifurcation. The MCA bifurcation is here in this image D. And so you already have very good news. It only concerns one M2 branch. And then if you look at the later phase, here, the last angio picture, you could see that there are two vessels that are filling delayed. So, you know, these two arteries are going to come out of this serpentine aneurysm. So we are beyond the MCA, and we have two vessels coming out of this serpentine aneurysm. So what does that mean? So if we illustrate it, this is the situation. Obviously, the aneurysm was much, much bigger than this, but we essentially have this branch, and then we have two MCA, M3, M4 branches coming out of this aneurysm. We have the bypass technique, and we heard that STA-MCA bypass is such a safe surgery. It is such a safe bypass. And if we can do it on the surface, this is the very safest bypass we can do. Toleration of occlusion time is very good on M4 branches. It's much easier to do it on the surface than to do it on the depth. So this is what I did. Nature gave us two branches of the STA. I revascularized these two branches, and then I went actually literally through the aneurysm, and it becomes a boulevard. And once I had hit the flow, well, that's very easy to control. And by reducing the mass effect, it was very easy to put a clip on this M3 branch. So something that looks very complex at the beginning, we can transform it into something that is, very safe. It's not about easy or not easy, but it's about safety. It becomes a treatment that is very safe. And the patient obviously recovered very well because of the mass effect that could be reduced. Now, this is another example, and these examples are more to illustrate all the strategies that we can use and to reduce invasiveness. So you can see that this patient was sent to me after having been explored outside in another hospital. And if you look at the angio, you think it's a small aneurysm, but obviously if you look at the CT, you already can realize that what you see on the angio is much smaller. And actually here you get a feeling the aneurysm is about 3 times bigger than what you see on the permeable part. And there's calcium. Very difficult to treat these MCA aneurysms. Was already explored, but lucky enough, they left one branch of the STA. So this again, this is the illustration of the image. The aneurysm was involving the bifurcation. And here I told you there was only one branch, so I did not do 2 bypasses. But what I want to illustrate here is that it doesn't matter if I put the bypass on this branch or on this branch, as long as because it's all communicating. So all I needed to do is to identify one of the M2 branches on the surface, and then I put a bypass here, and this complex aneurysm, I could then sacrifice that M2 branch and reconstruct the second M2 branch. So what does that mean? That means that I had a bifurcation aneurysm where I could not preserve both M2 branches, but I wanted to revascularize one M2 branch, and the other one I would be able to reconstruct directly. Now remember, this is the exposure. This patient was already operated before, so there's a lot of adhesions, a lot of, they did open the Sylvian fissure, and this you can see Surgicel. Just even opening the dura, you got some bleeding. So I did not want to open the whole fissure to be able to identify which M2 branch was the cortical M4 branch I was going to revascularize. So here was the strategy. By using fluorescence, we can identify which branch on the surface on the M4 will be the one branch coming from the M2 I'm going to occlude. So this again it's nothing particular, but it allows me not to open the fissure again, which was already opened in the past. So this is what we did. The first thing, you always have to do one ICG run to see if everything fills at the same time. So this was a spontaneous ICG run. This would be image A. There is no clip anywhere, and I just want to make sure everything is filling. This, remember, this is the aneurysm, and this is Surgicel. That's why it's not filling. And then I have access, I have to have access to the M1 and the neck of the aneurysm, but you can already see how adherent it is, and it's very big. And so I put the first time a clip on the vessel I was going to reconstruct. So I want to make sure I'm not going to bypass on the surface on this vessel. So it would be very embarrassing to put the bypass on the wrong M4. So this is the next run. So this was the region which was filling through the M2 branch I was going to reconstruct. So this is not where I want to bypass. So this is kind of a double security. That was number B. And now the next run will be number C, where I put a clip on the branch that I was going to sacrifice. Just coming out of the aneurysm, I put the clip on this branch just at the exit of the aneurysm. And then I didn't want to do the bypass down here because that would be much more difficult, deeper, a longer STA. And then now what I'm going to see without filling, and here you see the branch that I can revascularize. Now you could even argue here, and this is why intraoperative information is so important. You could even argue there is some backflow, which is not bad at all, that you could maybe even sacrifice it without. But again, because the bypass is so safe on the surface, I felt that it really needs to be bypassed. So we identify this now, and this is going to be the result. So again, only one bypass on the surface, and then we sacrifice that without doing a big dissection of the brain. Again, reduces invasiveness. It's not only about the craniotomy. Here, a completely different strategy now. 83-year-old woman who had severe progressive brainstem compression. I mean, she could not swallow anymore. She could hardly walk anymore. She was actually came to the hospital with a severe pneumonia because of her dysphagia, and she ended up having a feeding tube. Yeah, and this is the situation. She had a 3-centimeter vertebral artery, partially thrombosed aneurysm. And again, you see that the permeable part is very small. She's 83 years old. Well, obviously we need an angiogram. And here's the angiogram. So you can see, again, this is only the tip of the iceberg because the aneurysm itself was 3 centimeters in size. But we have to understand, and I put up this image here, which is key to the solution. What you see here is that a very good ICA. This patient had a very good ICA, filling a lot of the left hemisphere of the cerebellum. And the right pica was dominant. Furthermore, and filling also partially the left cerebellum. And finally, there was a small, and this is difficult to see here, I grant it to you, but there was a small, very faint vermian branch coming out of the pica of the left side. So, I mean, the decision was to do a combined endovascular and surgical procedure. So this was the endovascular part. There were no perforators along this segment. And we actually sacrificed the left vertebral. And because we were very, very confident that the ICA and the right pica would do a very good job on the cerebellum. And I did not plan a revascularization on this one, but a very simple decompression. So this is then at the same session, we sacrificed, and then we did a very small essentially a mini craniotomy of the posterior fossa, and just decompressed the clot. And you can see here the cerebellum. You see here below, you can see the aneurysm, the thrombosed part of the aneurysm. I had to still see the origin of the aneurysm on the vertebral and the pica coming out, but the plan was not to revascularize it. And then open the aneurysm and just empty it with the CUSA. You all know how you can take out clot from an aneurysm, giant aneurysm. And then with the CUSA, decompressing her. We can go on. So a huge aneurysm, no bypass, no proximal clip, because the endovascular did the job for us. And at the end, the only thing we still had was that very faint, there was a minimal faint retrograde filling through that faint vermion branch. And so that was perfect. We just could sacrifice that. And at the end, it was a really minimal. And this you can see here, this was the size of the surgical approach at the end. And this was before. This was 3 months post-operative. And I just saw her back actually 4 weeks ago. And she's doing very well. She has no feeding tube anymore. And she's extremely happy and grateful. So it's about understanding the anatomy. And we have so many tools nowadays that we can really reduce the invasiveness often. Now here I was going to approach still the last, that partial trapping can be an option in some of these very complex aneurysms. And this was a little bit what I wanted to illustrate up here to start. You know, many of the complex, giant, maybe fusiform aneurysm will involve some kind of perforator, lenticular striates, or maybe posterior fossa perforators. And then there's no way we can trap completely. So we can do partial trapping. And partial trapping, we can combine it with some kind of revascularization. And then if this is, again, illustrating it, if this is the M1 segment, carotid A1, M1, you know, this was one of those complex aneurysms. There's no way I can dissect out these perforators. Even trying to see the whole aneurysm is a risk because the perforators will be stuck to the wall, and perforators are just unforgiving. What I'm trying to illustrate here in the drawing is that, sure, you need some kind of revascularization. It can be intracranial, it can be extracranial, not so important. And furthermore, you can do a proximal inflow occlusion if you put the clip proximally, or you can even do a proximal a distal outflow occlusion if you put the clip distally. The bypass will fill here only the distal territory, and here obviously the bypass will fill distally and also retrograde down into the lesion for the perforators. So we also reported this, and we will. I will show you one case here. Usually these are young patients. Very interesting patient who had 36-year-old male who actually presented. You can see here because of this lenticular stride stroke. He had a stroke of the lenticular stride, spontaneous. He presented, and we found this lesion, which is an aneurysm. So it's a complex MCA aneurysm. Very close, you can already be sure it's going to be close to the perforators because he presented with a perforator stroke. And this is the anatomy again. This is the angio. And if you look well, the bifurcation is distal to this. So this is a proximal branch to the bifurcation, and the perforators must be somewhere here. And again, anatomy, and this is 1984. The illustration of the book we all know of Yazargil, you know, he taught us there's a lot of variations where the lateral frontal orbital, the prefrontal, and the striate come out. Now, let's look at the anatomy again. This is the 3D. Here, And look at this. This is the bifurcation. This is here. And this is the anatomy we have on this patient. There is a common trunk for the lateral frontal orbital and the prefrontal, and the perforators are all coming off of this branch where the aneurysm is. The aneurysm developed between those two arrows. Now think about the perforators here. No way I can explore this, and this would be the image with the aneurysm. There is no way in my hands, I can guarantee the patient that I can put a proximal clip here, dissecting out the perforators in this complex, giant, serpentine aneurysm. So here is the strategy we did. Let's put it into the surgical view. This is the situation we have, and this is what we want to do. I'm just going to put a clip distally. I'm going to occlude it here, and I'm going to revascularize. And then these two vessels are so close that I'm going to do a side-to-side flow. So this is the situation. Again, the first run to see the flow. And here you already see that there is delay, spontaneous delay, because when the flow goes through a big serpentine aneurysm, the flow is delayed. And then here is the two branches. This is the one coming out of the aneurysm. So this is the situation. And this is the one that is going to revascularize. I measured flow to make sure that it will carry the same flow once I did the anastomosis. Now, the other beauty of doing this is it's not deep in the fissure. It's rather superficial in the fissure. So we do the classic side-to-side anastomosis. It's a little bit technically different, but it's a very good anastomosis, a very high patency rate on these anastomosis. So we run the posterior wall. We run the posterior wall, and once and I interrupt the front wall. I'm going to maybe, for time issues, oh, it's already here. So now the front wall, we reestablish the flow. Now we've got the bypass here. I put now the final clip on the outflow of the aneurysm here. And now I still have a clip here because I wanted to, now I'm taking it off. And now we have this situation. I measure flow. The flow in the donor vessel was increased because it took over the flow. It gives you supplementary security. And obviously we control. And then this was 6 weeks post-op. You see it was the perforators, the aneurysm is gone, but there was this little remnant here. I had to put him on Plavix because this was enough to give him a little thromboembolic event still. So I put him on aspirin and Plavix after 6 weeks. And since then, he's completely asymptomatic. And the aneurysm is not completely disappeared, but in 10 months, it decreased by 35%. So it's just here the take-home message, distal outflow occlusion can be a last resort. Don't get me wrong. I'm not saying to do it on every aneurysm, but on pica and MCA complex aneurysms, it can be a very good solution in those where we don't have any other good solution. But remember, we leave some flow contact to the aneurysm. So I will not do it if I have another solution. But for these cases I illustrated, and I have other ones, I know that Bin Xiu also have some cases. We discussed this several times. It can be a good solution. So here's the thing. We need to reduce the risk of surgery. We have to understand better the natural history so that we can find the best strategy for our patients to do the balancing act with them, so that we don't push them on one side or the other. And that's all about strategy. So yes, you already heard it. Bypass is a very, very useful cerebrovascular tool in the armamentarium of the cerebrovascular surgeon. Thank you very much for your attention. Sorry. And I went a little bit over time, maybe. Sorry for that.
Thank you very much, Professor Luca Regli, for this didactic, outstanding talk. And as you say, balance is everything. Thank you so much. Now, maybe Professor Najir Abedi wanna say a word before moving to the next speaker?
Hi, everybody. I am
Professor.
really pleased to join us, to join you because I had some emergency family in Casablanca, and I am just coming back now, right now, and in the road the connection is not very stable. So I am here, and I would like to thank very much our speakers. First, Professor Binksu for this excellent presentation, and we know you very well. Last year we had the amazing workshop in Rabat. It was really very nice, and thank you, Lucas, for accepting our invitation, even if we invite you just 2 weeks ago, and you accept our invitation, and I'm very grateful for that, and to share this elegant and really a dreaming operating room. It's very fantastic. Thank you so much. So I would like also to thanks all the panelists, the third speaker, my friend Absamad Wahabi, and all the panelists for their participation, and also for the attendees. And I saw that you have a big number this afternoon. Thank you again, and we can, Fahd, you can continue the moderation, please.
Thank you, Professor Al-Abadi, for your nice words. And now we move to the third talk, and I invite Professor Yasser Arha, who is Professor of Neurosurgery at the Department of Neurosurgery of Hôpital des Spécialités of Rabat. He is also the director of this hospital, which is directed in head and neck medical and surgical diseases, and who was headed by my mentor, Professor Islam Khemlishi, before Professor Yasser Arha. Professor Yasser Arha is the first radiosurgeon in Morocco interested in vascular, skull-based, thoracic and functional neurosurgery, and of course radiosurgery. Totally involved in WFNS Rabat Reference Center of Training of African Neurosurgeon, and working with Professor Absamad Wahabi in the same department. This is why I asked him, Professor Yasser Arha, to present our mentor and the third speaker, Professor Absamad Wahabi. Professor Arha, you have the mic. Thank you. Yasser, we don't hear you. Now it's okay.
So thank you very much, Fahd, for the invitation. I would thank Professor Abadi for the invitation too, and it's a big pleasure for me to present Professor Abdessamad Al-Wahabi. Professor Al-Wahabi is the chairman of the neurosurgical department of the Hôpital des Spécialités in Rabat, the capital of Morocco. He took this place after our mentor, Professor Islam Al-Kamlishi, who is still working with us in the department, and we had just a few hours before the radiosurgery stuff, like every Thursday. Professor Al-Wahabi is again also director of residency training program and research in neurosurgery in Rabat Reference Center, Mohammed V University. He is a past president of the Moroccan Society of Neurosurgery. He's a co-chairman of the WFNS Global Neurosurgery Committee. He will have talk titled current management of cerebral aneurysm microsurgery on the vascular, one size that not fit all. Thank you. Thank you, Fahd.
Thank you, Professor Arha. And Professor Wahabi, you have the mic. Please share your slides.
Okay. Thank you, Yasser. Do you see the slides? It's okay?
Yes, it's okay. Nice. Thank you.
And just keep it like that. We can go to the mode.
Just put it on a screen, yeah, Jeff.
That's okay?
Yeah. Yes.
Better?
Thank you.
Do you hear me? Do you hear me?
Yes. Yes. Very
Okay,
good.
thank you, Yasir, for this nice introduction and for your kind words. It's for me a pleasure to participate in this seminar, and I thank Professor Najia Abadi for organizing, as well as Professor Lakhtar, the President of Moroccan Society, and all the members. Fahd was very active in organizing technically this webinars, the Morocco webinar series. So thank you also for our guest speakers who share with us this afternoon a very, very good and nice experience. And I thank the Wrigley, Professor Wrigley presentation is like an introduction for my presentation, since we know today that there is still place of microsurgery, and especially in complex aneurysm, and we have to deal with this kind of aneurysm because we see them more and more. And for the people who are not have not visited Rabat before, I'm working in the neurosurgical department. Rabat is the north of Morocco, Africa, and this is the team, and we have many residents coming from sub-Sahara Africa. So in the beginning, I want to pay tribute to these people who, famous neurosurgeon who really develop and promote the practice of vascular microneurosurgery worldwide. Of course, you know them, Dr. Yazarjil, Fukushima, Ernest Yanemi, and also I have to pay tribute to my mentor, Professor Khamilishi, who was the pioneer who introduced and developed the microvascular surgery in the neurosurgical department of Rabat. And his teaching has been impact in the development of neurosurgery in Morocco. And you see him with our colleague, Professor Azhari, who has followed his steps in developing vascular microsurgery in Casablanca. So let's start from the beginning. This is the paper that has changed the way we treat and managed aneurysm in last 2 decades. The ISAT has been the first randomized clinical trial that has showed, and controlled trial that has showed that there is a benefits with reduction of percentage of death and disability when we use coiling versus clipping. Of course, this study has brought important information and impact on the management of aneurysm hemorrhage. We know, despite numerous limitations, but what happened is that there are a very important impact on the practice of neurosurgery. There is a rapid decrease in number of aneurysm cases treated by neurosurgeon, and we are facing aneurysm more difficult, broad neck, giant, and dysplasic. And also neurosurgeons have to treat new aneurysm entity, the localized coiled aneurysm. And you see on this diagram the right slides that there has been an evolution of the treatment of aneurysm during the last 3 decades. And the first reaction was this publication has shown that when we compare the result of ISAT, and you can see here, with some important microsurgical series gathering more than 4,000, almost 5,000 cases, you see that the favorable outcome is similar in these 3 studies. What is very important to notice that all the studies have focus on our treated patient with good preoperative grade, with anterior circulation aneurysm, with small aneurysm. This is to say that if we stick with this indication, that the results are favorable for either procedure. And we know that clipping has been, as is still, a well-established treatment modality for cerebral aneurysm for many decades. But also in response to the ISAT study, the BRAT study has shown that there is no difference in clinical outcome when we compare the microvascular series and endovascular series, but also that there is a very important thing that there is a higher degree of obliteration with clipping when compared with coiling. And that means that there is also a low rate of recurrence. When we review the endovascular series, and you see here, this is a systematic review that has been published, gathering more than 8,000 coiled aneurysms. And in this study, we found that even in the cases that have been totally occluded after coiling, 91% of adequate occlusion, there is still a risk of 20% of patients will have their aneurysm recur, and half of them will need retreatment. When we compare this endovascular meta-analysis with the other publication on microvascular clipping of aneurysm, you can see here in this paper that the risk of annual recurrence is less than 0.5% when the patient has been controlled with angiography even at 10 years. Though that means that the clipping is the most definitive and durable method of treatment. But of course, this has also a response from study had shown that at 18 years, it is confirming that there is a higher risk of rebleeding after coiling at 10 years. So all this data shows that the microsurgery, coiling, the clipping has long effect, and there is a reduction of percentage of recurrence and retreatment are of course of bleeding. Another important factor to compare the two techniques is the cost. It is clear that in countries with limited financial resources, this is very important. And most of the study has shown that the endovascular is more costly than microsurgery. And where we are dealing with giant aneurysm, the cost of coiling is 13 times more than clipping. So it's very important to consider this element when we are discussing the indication. But there are also very important improvement and evolution in endovascular technique with the use of balloon-assisted embolization, the stent technology, the use of flow diverter to deal with larger or giant and complex aneurysm. However, the long-term safety of this technique is still lacking. And after great initial enthusiasm, there has a conflicting long-term results. And of course, today, coiling is not and is still not the solution for many aneurysm cases. And of course, the debate continues and will continue. And in a recent study, you can see here that the result of the study that gathered more than 7,000 patients that have been treated in 22 tertiary care hospitals from Europe, USA, and Australia, comparing coiling and clipping. And these are the conclusion of the study. The coiling is associated with higher 14 days case fatality and non-superior outcome at 90 days. So the debate is still here, but I think the question is not to clip or not to clip. The question is, what is the safest and most cost-effective techniques? What is the best candidate for either techniques? It is clear that both techniques have best indication, and we have to define this indication because we know that when we apply these two methods of treatment, both treatments are against aneurysm, not one method against the other. This is just few examples. These are aneurysms not suitable for coiling, either because they're small size, very, very small size, or they are giant, or because their neck is wide, or there are some feeders coming from the sac. But in the indication, not only the configuration of the aneurysm is sufficient to have the indication for decision making. And if we want to make a decision making for the management of cerebral aneurysm, there are many factors. There are patient-related factors. And today we have to divide the patient either young or old, less than 50 years versus 50, for more than 50 years. Treatment by clipping in the young patients, the comorbidities, the clinical presentation, the poor grade versus the good grade patient. If there is a compressive hematoma, which is indication for urgent surgery, and if there is some mass effect on cranial nerve, this is also indication for microsurgery. There are some aneurysm-related factors. Of course, the size, small versus giant, the configuration, dysplasic, if there is a thrombus, if there is calcified wall, the sac to neck ratio, less than 1.5, it's better to go for clipping. The location, anterior circulation versus posterior circulation. We know that most posterior circulation are better coil. If there is the aneurysm as rupture or not, and the vasospasm. And at the last group is the procedure factors, that's inadequate or difficulty of access. If there is some problem of complete exclusion, of course, the expertise of the team, it's very important. In our country, the cost is also a very important element to take into consideration. And the last factor is the patient choice, because also when the patient need to be informed about the two techniques, and sometimes he has to choose one of between the two. If we apply these different factors in decision making, I can see that there are cases that are better candidate for clipping. In our experience, the young patient less than 50 years, if the patient presented with dysplasic and wide neck aneurysm, most MC aneurysm need to be clipped. Giant aneurysm, difficult to coil. Distal aneurysm, particularly the distal MC aneurysm or the pericallosal aneurysm, if there is a compressive hematoma or if there is mass effect on cranial nerve. But there are also better candidates for coiling, the posterior circulation aneurysm, the poor WFNS grade patient, the old patient with symptomatic vasospasm. But also there are good candidates for both, for either technique. The anterior circulation, small, narrow neck aneurysm, WFNS grade 1 or 2 can be either treated by clipping or by coiling. And this group of patients, the choice of the patient is very important. The cost is also important. And we can choose one or either technique for teaching purposes, because this kind of aneurysm are easier for both technique, and it's very important to teach a resident and neurosurgeon how to deal with this aneurysm before they have to take care of more complicated cases. So when we review the trend worldwide regarding the management of cerebral aneurysm, and we can see that even with the coexistence of both techniques, still today, 50 to 70% of patients with anterior circulation aneurysm continue to be treated by clipping. And you can see on this figure that after the increased number of coiling with time, there is like a plateau around 60 to 50% of patients being treated either by coiling or by clipping. And in our expertise in the Department of Clinical Experience, we study more than 600 patients that have been treated from 2005 to date. 2005 was the introduction of the vascular technique in our department, and you can see here that 141 patients were clipped, and 184 patients were coiled. And you can see that this is the percentage: 30% were coiling, 70% clipping. And there are some illustrative cases for the indication of clipping in our department. This is I don't know if the video is coming, but is that okay for the video?
Yes, yes, we see the
this
video.
is the left dominant A1 ACOM aneurysm with subapparent WFNS grade 2 Fisher and grade 4, And you can see here, this is the left. We are preparing the aneurysm neck here. After this is a frontolateral approach, and this situation was right, straightforward. There is no perforance here, and the aneurysm is clipped. And this is the preoperative view of preoperative angiogram here, seeing this aneurysm. And this is the postoperative where you can see the clip. This is a second case where the clipping, after discussion with our colleague radiologist endovascular, this is a dysplasic right ACOM aneurysm, not favorable for coiling. Patient presented with subarachnoid hemorrhage, WFNS grade 2. And once again, after opening of the sylvian fissure, you can see here, this is dissecting left I1, and then dissecting both I2 here. This is the I2, the I1 here at dysplasic. And we use the first fenestrated clip here. This is the aneurysm here, trying to preserve this perforators here. The second one here, sorry. Sorry. So, once again, and dissecting both A2, and then we used the second fenestrated clip to reconstruct the A1, and the third one to reconstruct the artery. This is a patient who presented with the double aneurysm, one in MCA and another in ACOM aneurysm. It was dysplasic, wide neck, and discussed with our colleagues on the vascular. For them, it wasn't a case favorable for coiling, and we decided to treat the patient. This is the MCA. You can see this is a calcified aneurysm. This is the I2, M2, sorry. And we dissect the sac, trying to find the neck. It was large neck. For the sake of the time, we just to okay, so here we open the sac after a first clip. We decompress the sac, and we put another clip and removed the first one. And then we go to the anterior communicating artery, and you can see here, this is a very complex aneurysm. There is the bifidity of the A1, and we use a fenestrated clip. The sac is under the A1 here. The other part of the sac is here, and you can see here, this is a bifidity of A1, and this is a fenestrated clip. And we put the first one here, and then we put another clip on the other part of the sac. This is a third group of patients who presented with dysplasic MCA bifurcation aneurysm. And you can see here, sorry. Sorry. So there's a dysplasic broad neck and calcified right MCA bifurcation aneurysm, not suitable for coiling. And you, after opening of the Sylvian fissure here, the video is slow. And you can see here, this is the aneurysm sac, and M1 here, M2 here, and we use some dissection, and then we're going to use some very slight coagulation of the sac to reduce the sac and to get some room for placing here a clip. And then we prepare the neck for final clipping. Okay. Okay. The fourth case is the patient that presented with some mass effect on the third nerve. This is a giant partially thrombosed aneurysm, become aneurysm. And you see here the aneurysm here, the thrombosed part. And we go through microsurgery, and after opening the Sylvian fissure, you can see here the aneurysm. And then it was easy. It was a very narrow neck here. This is the carotid artery. This is the PCOM. And then this is we put a clip here on the neck. It was straightforward. And then we opened the sac, and we decompressed the sac, removing thrombus to decompress the third nerve. The last case, it's a very interesting case. It's a very young, the youngest in the series, 30 years old boy who presented with basilar trunk aneurysm with sac neck ratio not favorable for curling. And we decided to go for a microsurgery, and you can see here on this reconstruction that the aneurysm project 3 millimeters above the posterior climatic process, and we operate the patient by so this is the case. Frontolateral approach, opening, this is the case, rupture basilar trunk through the transsylvian fissure. We open the sylvian fissure. And then we dissect the carotid cistern and open the Lillquist membrane. The video is slow, and then we the video is slow, and then we found the aneurysm. Sorry, it doesn't work here. And okay, and we can clip this patient with this from this approach. This is the study population. More than 900 patients has been treated in the department for last 35 years. And you can see here, this is the two group, clipping 441 cases, and coiling 184 cases. This is just some results. When you compare the two groups, this is the group of coiling here and clipping, and you can see that both groups grade 1 and 2 are similar, 88% coiny group, clipping 86%, the poor grade, the rest of the patient. Most of the patient that has been clipped are the MCA and ACA, while most of the posterior circulation were coiled. And this is the, when we compare the outcome at discharge, we found that we had the same good outcome in the both group when you use either technique. So in conclusion, the endovascular technique have still many limitations. Aneurysm clipping should be developed and maintained as routine neurosurgical activity. And it's in our practice still the best treatment option in 50 to 70% of aneurysm. It is cost-effective technique which provides excellent opportunity of learning, particularly in developing countries with limited resources. And both microsurgical and endovascular technique yield to comparable results, provided the selection criteria of each procedure are respected. Thank you very much.
Well, thank you, Professor Wahabi, for this very interesting talk and illustrative cases. May I ask all the attendees and the panelists to be involved in the discussion after the presentation of clinical case by Professor Tamir Hassan. Professor Tamir Hassan is professor of neurosurgery in Alexandria, Egypt, in the university in Somwa University Hospital. He is a Japanese board certified neurosurgeon and the director of vascular neurosurgery unit at the Department of Neurosurgery in Alexandria. He's also the director of Research Center of Computational Neurovascular Biomechanics at the same university. And may I ask Professor Tamir Hassan to present his case about de novo partially thrombosed giant aneurysm complicating STA-MCA bypass stamp after 3 years. Thank you.
Thank you very much. I'm very happy to join you in this meeting. It's a very successful webinar. Many thanks to the Morocco Neurosurgery Society and to Professor Naji Al-Abadi. Thank you very much. Can you see my screen?
Yeah.
Yes.
So I want to show you this case of, this is a 30-year-old male teacher. He noticed that he has a progressive deterioration in memory since that was in 2009. As you can see here, the whole carotid artery is dysplastic, and we have two aneurysms, one located at the cavernous portion, and the other one is located in the neck. You can see the partial thrombosis of the aneurysm. We did a balloon occlusion test under local anesthesia. We did the bilateral femoral puncture, and we closed the carotid with balloon, and then we wait for 20 minutes. But the patient did not pass the test. He suffered from neurological symptoms, so we stopped the test and we considered the patient for bypass surgery. So I was happy that this patient has, let me show you in these previous slides. You can see here the STA is big. It's more than 2 millimeters. And I was very happy because of this big STA that will help us in doing an easy bypass. So we did an STA-MCA bypass, as you can see here. And bypass was successful. This is a CTA after the bypass was done. After 3 months, the patient come back with headaches. So severe headache. So we did an CT angio, and you can see the stump of the bypass has grown into this fusiform-like dilatation. We give aspirin and we wait, but after 2 years, we have this. So this is the stump of the bypass has developed into, become a giant partially thrombosed aneurysm. So what to do now? Should we go for a flow diversion? Should we do a new balloon occlusion test? Should we do another high flow bypass? I want to know, should I continue or open the floor for discussion?
Maybe we can open the floor for discussion. What do you think, Professor Lakhdar?
Anybody could treat this patient by a different way, or
Yes, okay.
how do we deal now?
Yes, maybe our guest speakers can give their opinion on this case.
But how is the clinical aspect now? Is just a headache? He
Only,
had,
yes, now
no deficit, motor deficit or anything, only headache.
yes, no motor deficit.
Well, it's an extremely unusual case. I never saw a similar case. So I mean, wow, very impressive. You see, I mean, obviously this patient has a vascular disease that is beyond a focal aneurysm. So he already started with, I mean, he's 30 years old, at least when the story started. So he's probably 32 now. And I mean, his carotid was absolutely dolichoectatic and dysplastic and with aneurysm. His his STA was already pathologically wide, I mean that CT angle that you showed with the STA, and I was very impressed. I understand your thought that you say it's a fantastic donor vessel. At the same time, it's almost, it was meant to happen because I mean, that STA was not a normal STA to start out with. Now, I think that all doesn't give you us and the patient the solution. I'm just trying to brainstorm while I'm talking. Can you really show us where the microanastomosis is? So my question is the aneurysm really on the STA? And it okay, yes, here this is a good picture.
Yeah, this is the M1. You can see here.
Yeah. Well, I mean, definitely you cannot leave it like that. That's obvious. And that STA now, I mean, it's the size of his carotid when he started out with. So I mean, you have to do something about the mass effect, and he definitely has not collateral flows because that STA is so big. So I think that the best would be to take. And I'm sorry, his carotid in the neck is closed all the way, common, external, obviously not.
Yes,
and the common is open and normal now, or is it dysplastic also?
I closed the carotid artery and the neck.
But the internal, because I mean,
yeah.
but
After
the common.
We did the ligation in the neck, and then we put a clip on the carotid proximal to the pecon.
Okay, but I mean, the common carotid is normal, or
yes.
Or is it also dysplastic? My thought is a little bit this. I mean, if the rest of his body has normal vessels, I would try to take a vessel that is not his cranial vessels. So I would probably go with a vein.
Most of the vessels on his left side of the body is dysplastic. You have to do something on the right side.
Yeah.
That's very strange.
Yeah. So I mean, he definitely has some kind of a vascular syndrome, and you're right. I mean, these can also involve peripheral vessels very often. Heart is normal.
Heart is normal.
But I would definitely take that. I mean, this has to be sacrificed. I think his mass effect is very large, and we have to hope if his MCA is normal, I would put probably a vein. If his veins are normal, I would probably put a vein, and to the common carotid then.
Okay. Any other?
But Ben,
hemodynamic problems, no?
Yeah, I agree with you, Professor Rickley. I wouldn't choose this enlarged STA as a donor artery.
Very difficult.
Now it's a very, very difficult situation.
You know, this is now, I mean, because he definitely brings a lot of blood through that STA. So one could think about going more proximal, you know, maybe on the, because I see that his supraclinoidal carotid is still there.
Yes.
So you put the clip proximal or distal to PCOM?
Well, I don't remember the details that were 2009, but I remember that we closed the carotid artery in the neck.
And then, and in the cranially?
In cranial, I don't remember. I don't remember. I remember that we
know,
trapped the aneurysm. So there was a big cavernous portion aneurysm. We trapped it, but I don't see the clip. Probably we did just proximal ligation in the neck.
Okay.
Dr. Tamer, you are of course neurosurgeon and you do endovascular treatment also. Do you have any solution? Endovascular solution, even we know that it's there is a bypass and it's very difficult, of course, to put any fluid departure. But still now there is only headache, even if there is a mass effect. If my question is for you, there is any solution by endovascular?
Okay, let me continue because there's another problem.
Yeah, I know. Okay.
So what we did is we did a balloon occlusion test. Actually, the balloon occlusion test was done just to understand what happened in the circulation during those 3 years. And you can see this is a balloon through the STA. We occluded the STA with balloon, and then we injected the carotid artery from the other side. We found collaterals coming from the ACA and PCA covering the whole hemisphere. The patient didn't suffer from any neurological deficits during the balloon occlusion tests. So what we did is we just occluded the bypass. We occluded bypass.
Sorry.
And then after occlusion, the patient was doing fine, no problem. And then after 4 years, again, the patient came us with another headache. And you can see disappearance of the giant aneurysm complicating the bypass. And we now have a fusiform dilatation of the posterior cerebral artery on the left side, as you can see here in 2016. So we cannot do anything with this PCA because this PCA functioned for the PCA and MCA. So another point of discussion, what should we do now with this new aneurysm?
Yeah.
So now we occluded the bypass and we have a de novo, another aneurysm coming after 4 years on the posterior cerebral artery. And that one is vanished and the patient did for 2 years very well and they start to have headache and then we have this.
Try again endovascular, something by endovascular. I think microsurgery is not a solution for this case.
Yes, and this is what we did.
It is a disease of vessels, so we need to understand what happened in this disease. You should to explore.
We sent the
if there is any disease of vessels, and maybe it's not the solution to to follow any new de novo aneurysms to treat it. There is a disease, and we need to understand what happened before to go to treat one by one.
So we didn't have a chance.
Very, very difficult cases, and I think the understanding of what happened if each time you treat one of the aneurysm, what happened after. We need to understand what happened before of course.
The first time when we
offering for the patient any procedure.
Okay, and the first time when we did the bypass, we didn't consider that this patient has some sort of arthritis or something. So we didn't take a biopsy. And after that, we managed through endovascular by ligation of the vessels. And now we did a flow diversion. We put a long Leo stent, and then we put a silk stent inside. And you can see now the vessel was reconstructed. and the patient up till now is doing very well and he is very happy. So to sum up what happened with this case, and this is the picture in 2009, then we did the bypass, then the bypass after 3 months had this stump, another joint aneurysm developed on top of the stump. Then we did a balloon occlusion test in 2011. In 2016, we did a flow diversion for another de novo PCA left aneurysm. So actually, this case was managed in a single department, and I want just to send a message that vascular neurosurgeons need to acquire neuroendovascular skills, because these skills will help them to improve their neurosurgical skills. And hyperpractice is better for the management of the patient complication.
Yeah.
And this is the message that I want to send from presentation of this patient. Thank you very much.
Oh, fantastic management.
Yeah.
Congratulations.
Thank you, Professor Tanner, for this very interesting case. Is there any other comments or questions from the floor for the speakers and also for Professor Tanner Hassan about this very illustrative and interesting case?
Professor Akhdar?
Yes, Professor Azhari.
First of all, I would thank the Moroccan Society for this webinar and to thank our speakers and to say hi to my friend Pincho and to
Hi.
thank Professor Regli. I have a question for Professor Regli. You know, this you show us very nice technology in the operation room, and your conclusion is to predict how is the aneurysm, how is the configuration of the aneurysm, the anatomy, and you show us one aneurysm. When you put a clip on this aneurysm, the monitoring is going down, and that means we don't know how is the situation in every case. In second webinar in Moroccan Society, I showed some cases, and I make a title is what we expect and we define in surgery. And really, it's very important what we have. We have only the angiogram. We have our anatomy, knowledge, the angiogram, and we don't know how is it really. And you are I was very interested by your presentation when you said we have to understand before going. We have to understand how is it, but it's not all the time the case.
Correct.
And sometimes we expect some things and we find another things more complicated because it's vessel diseases. There's a lot of factors we will find and we will manage in this case, in this surgery. My question for you is: did you find some things with all the technology that you have in Switzerland? In Switzerland, you have very nice operation room with a lot of technology. Did you find some things or some? You have some angiogram, also angiography, which are more fidel or more sophisticated. Could make you close to the real situation? That is my question for you, yeah. Professor Regli.
Thank you for your question. I mean, you're absolutely correct, and I very much like the title of your presentation that you mentioned, that what we expect and what we find. I would maybe answer this. There is two things. What I meant with we have more or better imaging today and more complex reconstructions. We can have MRI, CTA, angio. What I'm saying, first of all, is that it would be terrible, and I think if somebody, just because he didn't look well at the angiograms, at the examinations, he missed something he could have known before going in. which actually is what I call negligence. So, you know, if you're negligent, the way you look at the pictures and you end up finding out something in surgery you could have known, I think that is very bad. And so that's one thing. The second thing is, because of all the feedback we get during surgery, the learning curve of our residents is really more steep, in the sense it is more accelerated. And even for me, for example, now I'm taking another example, measuring the flows quantitatively when we do reconstructions, when we do trapping, allowed me to understand even more how connected the collateral flow is. So yes, the feedback we get every day in surgery through the measurements, through the imaging, advances our knowledge. But you're absolutely correct that it is not like a one-to-one. And sometimes we have surprises. For example, the patients you mentioned again in the neuromonitoring that went down, you know, obviously I looked if I had missed a perforator. The obvious thing is that, you know, the clip did close a perforator. But I guarantee you, I've done a lot of MCA aneurysm. I couldn't find the reason why this patient, the flows, I mean, the potentials went down. Flow was good through the M2s. I could not identify a perforator that was not visible or was without flow, but still the potentials went down every time. I don't know why that happened on these patients. And tonight, thanks to our colleague who presented this fantastic case, I learned something I had never seen before. I mean, this is diseased, and I think, you know, but even, you know, we learn today again, although we know it, aneurysms are not a focal disease. They are a segmental disease very often. And this complex aneurysm we're talking about tonight, it is way more complex than just putting a clip or a coil into a vessel or into a sac. There is, and I think, you know, the future will be molecular and cellular understanding of the disease. So somebody mentioned it during the discussion before, you know, it will end up that maybe we will have a way to treat with medications aneurysm one day. I'm very hopeful of that.
Thank you very much.
I have a question for our two speakers, Professor Bing Su and Professor Luca Regli. It's about the bypass, which bypass is efficient for each patient. And there is a software, we saw it when we was in a steamboat with Fadi. It's to choose which one is very efficient in according, of course, according of the disease. There is Moya disease, Moya disease, or in sometimes in some giant aneurysm like you shown us today. The software is, you know, that de Nova. It's I forgot it totally, but it's a very which is very important to choose which bypass you have to show, because you show the different bypass that you can perform in when you have, especially in some the Moya disease or some revascularization. Not in the cases. It's most of the time in the Moya disease or other disease of the vessel.
Bin, you want to answer that?
You go first.
Oh, no
voice.
Yeah. Luca, no.
Yes. Microphone, right. In
Steam, don't hear you.
Now you hear me, I think, no?
Yes.
Yeah.
I'm not sure I picked up in Steamboat that lecture or that, so I'm not sure. But the thought is, obviously the answer theoretically is the most simple bypass and the easiest and the most adequate match of flow. The challenge we are facing is we still have no good method to reliably measure collateral flow in the brain. And so I think sometimes we bypass too often, and we bypass a little bit beyond what it is necessary in preservation, in flow preservation. At the end, my philosophy today is, and that's again the colleague you illustrated with this case, the purpose is that the brain does not stroke. The purpose is not the bypass. The only purpose is to avoid a stroke. So if the bypass closes 1 year, 3 months, 10 years down the road, and the patient doesn't do a stroke, that's fine with me. And you know, the progressive clip occlusion is a way around bypassing. It's a way to develop collateral flow. But I'm not sure, Najia, about the program. I mean, I'm sure it's a modelization. It's a mathematical modelization program based on NOVA, probably, on trying to predict. And for ischemia, I mean, ischemia, that's, there we want to augment the flow, obviously. And there, the Moya, nobody has more experience than Professor Xu Bin.
Yeah, Professor Abadi, actually the nature collateral, normally we can estimate it, use Bloom occlusion test. We can occlude the ICA. Sometimes we can use small balloon to occlude the MCA branches to estimate the nature collateral. And just like Professor Luca Wrigley mentioned, that there's no very accurate calculation on the nature collateral pre-operatively. So before the operation, we should make sure to have the enough replacement of the blood flow. So the sometimes we also use progressive occlusion technique to, because if you occlude the parent vessel of the aneurysm in 7 days, normally the nature collateral of the ACOM and PCOM can also increase. So it makes sure to avoid the lethal ischemic condition.
Okay.
Now we are developing some electronic progressive clips with Professor Juha Hannesniemi. We are just working on this.
Mm-hmm. But the software, I think it's named the NOVA. Luca is right. It's the NOVA. I think it's just software to choose using the how the pressure in different branches, and to choose which the best effective bypass. I think it's
yeah, but actually, you know, the vessel is a soft vessel. Mm-hmm. When you clip one branch, actually the another branch may expand it immediately. So sometimes you couldn't calculate this branch's blood volume because the delta P changed. Actually, the blood volume also can change immediately. So it's very hard to calculate according to some software. Mm-hmm. It's very complex.
Okay, thank you.
Mm-hmm.
Ben, maybe how often do you do high flow bypasses? What is kind of generally called high flow bypasses? I'm asking because I'm moving. I will do everything to try to avoid a high flow bypass.
Yeah, Professor Rickley, I only do the high flow bypass normally for the, I mentioned this, for the school-based carcinomas. If they want to sacrifice the ICA, sometimes it's a dominant side. The ICA not only feeded the same side hemisphere, but also the frontal lobe of contralateral. So this kind of dominant side ICA, I will use the sulfoxaflor to do the high flow bypass. Normally, as you mentioned, that in the aneurysm bypass, normally I just use a radial artery and sometimes combined with the STA MCA. So it's not so high flow.
Yep.
Yeah.
Professor Wrigley, my question is for you. It's about in Switzerland, not only in Zurich, but Geneva and others, and Lausanne. And in which percentage you continue to do microsurgery versus clipping? It's the same percentage that our friend Professor Wahabi shown us, or it's a little bit different, because we know that in some European countries, such as France, because we are more closer than French neurosurgeon, and we know today that we have a last week one webinar with one friend from from the endovascular team of La Pitié-Salpêtrière, and now we know that they are more. They did more endovascular, of course, endovascular procedure than microsurgery. In the percentage, I think it's 70 or even 80 versus 30.
Yeah.
And how is the situation in Switzerland?
I think it's very much like our colleague presented very nicely in his numbers. It levels around 50-50.
Mm-hmm.
And I think it was extremely well summarized. There are some that are very clearly better done with clipping. There are some that are clearly indication, and there is a pretty big amount where both can be proposed. I think the big challenge is for our young colleagues. When what really becomes, I think, the standard today is to decide in an interdisciplinary and multidisciplinary way. And when you have a younger colleague that does microsurgery, it is very difficult for them to stand up and say, but this can be clipped. I think we have to really defend them that clipping is a fantastic approach. And, we see the more we let people do endovascular, the more we see also that they have complications like we have. Mm-hmm. And we really have to decide together. And 50-50 is the way that generally in Switzerland, and I would also think in Germany, is leveling out.
The same question for our friend from Algeria and from to the.
Yes, I have a question to ask you.
How is the percentage microsurgery versus endovascular treatment
in Algeria?
Yeah, in Algeria and
in Algeria, we don't. The field of endovascular is not very developed. Yeah, so we use more microsurgery clipping than a few cases are embolized. This is. So I have, sorry, Najib, I have a question for Luca Wrigley and Bing Xu. So the presentation of Professor Professor Abdel Wahabi is about two fields of treatment. So we have the clipping and the coiling. Do you think there is a third part of the treatment, which is using bypasses with the ligation of the parent artery? So what do you think about this? What's the rate of your own experience of this for this third part of treatment?
Well, I don't have the numbers right in front of me. I would say then you could then say there's four treatments, which the other one obviously is flow diverters.
Mm-hmm.
So I think the way maybe one could answer it's a little bit strategic or politically correct is that I think the same way that coiling should be done every time that you can coil, they shouldn't do a flow diverter. And I think for surgery it's the same. Every time you can clip it, I think we should not do unnecessary bypass or trapping. However, it is very quickly in complex aneurysms. A complex reconstruction will be more dangerous than a trapping and a revascularization. And probably it's the same for endovascular. I'm obviously not the specialist of endovascular, but I think that a bad coiling, it's worse than a good stenting, but a good flow diverter. So you say, are there three treatment categories? Yeah, it's still microsurgery. I think we should keep to endovascular and microsurgery. And then the question, I thought you were going to ask if I agree that every microsurgeon should also be a endovascular. I agree that the knowledge increases. By looking the endovascular, by doing endovascular, we increase our knowledge for microsurgery. And definitely my colleague endovascular, Zsolt Kulczak, he comes on a regular basis to look in surgery because he learns by seeing the aneurysm, by seeing the AVM from the microsurgical perspective. So I think we have to communicate. The very top level, it's going to be hard to do both at the very high level. I think that still is true. But so if you do both, you still have to have a focus on one of the two.
Yeah, Lucy. Actually, I'm doing both the endovascular treatment and the open surgery for aneurysm. Maybe 10 years ago, I have around 30 cases per year to do the bypass for complex aneurysms. But now it's only about 10 cases per year because of the use of the flow diverters. It can it depends on the location of the aneurysm, like in the cavernous sinus, cavernous segment. Actually, now it's unnecessary to do the bypass. Only treated by the flow diverter, sometimes even covered stent. It can be get very good result. So most of the paraglenoid giant aneurysms also can be used flow diverters. But the more distal giant aneurysms, especially in the M1 or M2 segment, we still use a bypass, especially just like Professor Luca Regri mentioned, sometimes we still need the distal clipping combined with a distal bypass. This is a very good treatment for preserve the very important perforators for for the basal ganglion and the thalamus. Yeah. So the more distal giant aneurysms, we still need the bypass. Because if you use in the MCA giant aneurysms, actually now the flow diverter is still off-label use.
Professor Tamer, how is your answer about this matter?
Well,
I mean,
Coiling is
in how percentage you did microsurgery versus endovascular
so
treatment?
easy aneurysms for surgery are easy aneurysms for coiling.
Yes, I know that.
So we are trying to save the money because patients funds themselves in Egypt. So
Sure.
we can do the clipping, we can do it. If the case is difficult for clipping, so we go for the endovascular procedure. So the percentage of clipping is much higher than the endovascular procedure.
Yeah.
Much higher.
Professor Lakhdar?
I believe in myself that
Yes, Professor Ali.
The cost is one of the
clipping is still a very cost-effective way to treat aneurysm.
Yes, I'm practicing in a private hospital, and I had in my team one of the famous endovascular radiologists, and many, of course, all the treatment of aneurysm, ruptured aneurysm, even non-ruptured, it's taken in charge in the university hospital. So this. We are actually one of the reference center for the endovascular treatment. So many patients, when they arrived in our department, they have before seen by the other neurosurgeon from the other cities in Morocco, and then to convince them, sometimes even if the indication for me it's not the good for the endovascular, to change their mind about this indication when they had before the neurosurgeon from other city to told him about the endovascular, open the brain, open the it's still something the special. So a patient, the decision of making by the patient in my opinion, in our hospital is very important. And sometimes even we decide with our endovascular to treat them by microsurgery. They refuse, of course, the treatment of microsurgery because they are referred to our hospital first for endovascular treatment. And this is very. This is sorry.
We noticed in our statistics that the percent of redo surgery, is much higher in endovascular compared to open clipping. So the percent of doing something for the patient, putting another coils, put a stent, is much higher in the endovascular than surgery. Surgery is better in the redo what we're going to redo. Clipping has a better results.
This is why I precise in the beginning we are in the practice private practice hospital, so the cost is in the second second step, if I can say that. Okay, thank you. So
Professor Hamlishi, then
we have
Professor Ibn Ali. Sorry, Professor Hamlishi, Professor Ibn Ali.
Yes. Do you hear me?
You wanted to say?
Yes. Good evening, everybody. I would like to thank all the speakers for their very nice presentations. I have two questions. The first, for the beginners, what to do if the vessel is injured? For example, STA is injured, what to do? And the second question, for the complex aneurysms, what do you think about 3D printing techniques in the understanding and management of such lesions? Thank you.
A very, very good question. For the 3D printing, I'm back to what we discussed earlier. The more information we get, the better. So I definitely think that having a 3D representation in space, 3D printing is very good. Holograms could be the next step. So I think that is extremely good. The challenge on having that is to have, I think, automatic segmentation of the images. Because today, if you want to really have a high quality of that, you have to do a manual segmentation probably. and that takes a lot of time. So it's not realistic that somebody spends, 3 hours to reconstruct it. So the day we get good automatic segmentation of the vascular anatomy, I think 3D reconstruction, hologram printing, any kind of representation will be very helpful, especially also for our younger trainees. The other question was about the STA. Well, I mean, Bing-Xu showed us a very elegant way to harvest the STA, and it probably doesn't happen to him. It has happened to me that I injure the STA, and you have to reconstruct it. It is amazing how well vascular reconstructions work. So you can repair the STA if you injure it. And I think you should repair it. And if the segment gets too short, then you can do an interposition graft with a radial artery or some other artery. But you should not give up the bypass if it's necessary because you injured the donor vessel. Last but not least, I would say, obviously, I harvest except when I take it from underneath, like you saw it in the nice video from Shanghai. Otherwise, I take it with a microscope just to reduce the risk of injuring.
Thank you.
And for example, sorry, carotid endarterectomy nowadays, I do skin to skin with a microscope. I think it's part of understanding. You see better. You got better lighting, the resident sees better, the trainee sees better. We really should use the microscope for almost everything we do.
Thank you.
Thank you. Professor Khamlichi. Is there any other question? Professor Khamlichi, you still, yes, stay with us.
He is connected.
Please, Professor Khamlichi, can you unmute yourself?
Yeah, he's connected, but he's muted.
Yes, Professor Khamlichi, you wanted to comment something?
You hear me now?
Yeah, of course.
Or not?
Yes.
Yeah, just
okay.
to say that I was very happy to attend this webinar and to listen all the speakers for their outstanding lectures, and also I think to thank the organizers for this nice session. When I see this progress in vascular surgery in Morocco, in North Africa, I sometimes come back to the history and to this evolution, and I would like just to remind you. And I'm happy to see Professor Lucas here. In 1977, I visited the department where you are now at the time of Yazargil, when he was, of course, the icon, and he's still the icon of the beginning of microsurgery. And after having spent some time in Lausanne. And I remember when I came back to Rabat in 79, I found that my mentors, neurologists and neurosurgeons, and my African colleagues in different meetings, writing and saying that aneurysms are rare in our places, in Africa, in the Middle East, in South Asia. And maybe if you look to some papers published even by famous neurosurgeons like Ramamurthy in India at that time, they stated that aneurysms were very, very rare. And it was absolutely necessary to convince these colleagues that they're also here that at elsewhere. And we did our first autopsy study on around 250 brains dissected, and we found that the aneurysm exists with the same proportion, either in adult and in children. Even I remember 50 brains of fetuses. And this was the first confirmation in our places that the aneurysms exist. And then we started, of course, to treat them and to show the cases. And today, when I see this huge progress, all the colleagues who presented, Professor Wahabi, our colleague from Professor Hassan Tamar from Alexandria, it makes me, of course, very, very happy. The problem is that vascular neurosurgery is just maybe starting in all the rest of Africa, in sub-Saharan Africa. And I would like what I have seen through the lectures of Professor Binkso regarding the practice of the bypass, regarding from Professor Wrigley about the treatment of complex aneurysm. I would like to ask them to share with the African young colleagues their experience by, of course, participating more on these webinars, by participating in the meeting, and also by maybe offering a possibility for visit, because this is the only way to improve vascular surgery everywhere. There have been a lot of discussion regarding the progress of microsurgery in front of the endovascular. I think for me that endovascular is really progressing, and it will progress more and more. The problem is with how to maintain and make progress in microvascular surgery. What our colleague Najia said regarding many colleagues from private practice sending aneurysm to the university hospitals for endovascular is maybe there is also some lack of microsurgery in many places in our countries. And this is the reason why they go to the university. And it's a great responsibility of the colleagues now at the university to maintain this training, and also to maintain the exchanges with the outstanding department and colleagues like those who we have heard this evening. So I'm so happy to have listened to all these lectures and the discussion. And thank you, Najia. Thank you, the organizing committee, for the effort, of course. And you have to continue to maintain the teaching with Abdul Samad Wahabi, Azhari, and others, the teaching of microsurgery, because as I said, endovascular is going to progress. And you see that our colleague in Egypt, he said the majority are treated with endovascular. In Europe, it's 50/50, but there is, in this time, if neurosurgeons don't maintain this practice, endovascular will go up very, very quickly. And it will be a pity, of course, for the patients, because we have seen how difficult are some cases and how microsurgery is needed. Thank you.
Thank you, Professor Hamlishi. May I ask a question to Professor El-Wahabi about microsurgical versus endovascular treatment of vascular pathology, not about technical aspects, but about the discussion with the neuroradiologist, the endovascular, and the patient, how to convince both with the surgery. You showed obviously scientific arguments and papers, but it depends on the teams in everywhere. It depends on the team. Not all the neurosurgeons and the endovascular surgeons refer to these scientific arguments. So, and many cases are suitable also either for surgery or for endovascular treatment. So what are the arguments and how to convince both the surgeon and mainly the patients for each treatment?
Thank you, Professor Lakhdar, for this question, very important question, because this is really the beginning of the decision making, is to have a team, endovascular team, that understand what is going on when you are operating. And we have invited some colleagues from endovascular team to come to the operating room to see what we are doing, and we visit them to discuss with them the angiography. It's very important to have this kind of discussion. All the decisions are made. The neurosurgeon is involved in every single cases of management of aneurysm. For us, the sites like that. There are patients with posterior circulation aneurysm, WFNS grade 4, 5, patient with symptomatic vasospasm, all patient comorbidities, endovascular, if they can do this. Patient with dysplasic MCA aneurysm, with the giant aneurysm, with the young patient, less than 40 years, we go to microsurgery. Now, as it was said that there are one, for example, the small, as I said, that's a small aneurysm with very good neck, either for surgery or for embolization, good grade patient, anterior circulation aneurysm patient. In this situation, there is two other factor of discussion. The choice of the procedure, the cost of the procedure, of course, and the discussion with the patient, what is the long-lasting effect procedure. We know that in 90% the embolization, we can have a recurrence at 5 years, at 10 years. With the microsurgery, less than 1% per patient with this kind of information, we can convince them. But at the end, is his choice. So it's very clear for us. There are cases that are go directly for embolization, the other for microsurgery, and the one that we can do both, we discuss. Because it's also very important for the young that these easy cases should be treated also by the resident, as I said in my presentation, because you can't rely on this neurosurgeon when you have to treat complex cases, as I've never put a clip on the neck of a small aneurysm of PCAM, for example. So it's very important for both team to treat this patient. So this is our strategy of discussion with our team.
Thank you. Any other question? I think it's too late. Thank you, all our speakers and panelists. May I ask Professor El-Abadi to conclude this webinar?
Oh, thank you. I'm so sorry that I will be there late, so I think you have to conclude. But I would like just to thank all the speakers for their brilliant talks, and also for the panelists, especially our guest from Tamer from Egypt, who shown us a very spectacular and difficult cases which even our speakers from Lucas and Biksun find it very difficult and not easy to of course deal with it. And a special thanks for all the Moroccan society for their help for organizing all these webinars, and also for the attendees. We have today, I think, more 80 attendees, participants, knowing that it's really very late and at the end of the day after a hard work day. So thank you again for accepting our invitation, for sharing your experience with us. And I hope we meet you in the future. Next future and soon for I think Fahd forgot to show you that we are organizing in maybe 1 month between 18 to 19 our courses, African courses for a young neurosurgeon. Is the WFNS Reference Rabat Reference Center, who is organizing usually every year his course, this course, international course, and it will be this year between 18 to 19 November 2020 on a virtual mode. Unfortunately, because this health situation on COVID, and you all to be safe, and thank you again for your to be with us. Bye bye, and hope to see you soon in person.
Bye. Thank
Bye.
you.
Thank you. Good night.
Good night.
Bye, Bin.
Hi, Lucas.
Au revoir. Merci.
I am waiting. Oh, thank you, sir. Merci beaucoup. J'attends la petite adresse là de notre ami le président.
Ah, Andreas, oui, bien sûr.
Ouais.
Oui.
Non, pas ah oui, Andreas, le Suisse, pas l'Européen.
Oui, Robert.
Voilà, c'est ça, parce que les deux ils s'appellent Andreas comme par hasard en ce moment.
Ouais,
L'Européen, il s'appelle Andreas Demetriou. Si vous
ah,
connaissez,
non, mais Robert.
Voilà.
Andreas Robert. Allez, bonne
Ça
nuit.
m'a fait plaisir. Le bonjour chez vous, à vos enfants et votre épouse.
Merci.
Et puis vraiment, merci d'avoir été avec nous. C'était vraiment très bien.
Grand compliment. C'est très, très bien organisé et très intéressant.
Merci. Et je suis désolée d'être là un peu tard. Pour des raisons familiales, j'ai dû me déplacer dans une autre ville et donc je suis arrivée sur la route. Casa et Rabat, la connexion n'était pas très bonne au début et donc je voulais pas que ça démarre mal. C'est pour ça que Dr Darkaoui, qui est mon assistant, mais en même temps qui est le vice-président de la société marocaine, et donc il fait énormément. D'ailleurs, il est tout le temps en contact avec les speakers. Et il fait un travail remarquable. Je le remercie d'ailleurs. Profite pour le remercier.
Le webinaire a super bien fonctionné. Allez, bonne nuit.
Merci beaucoup.
Merci.
À bientôt, Lucas.
Très bon webinaire. Bye.
Merci, Sebrahim.
Bonsoir tout le monde.
Merci, Sermo. Comment ça va? Vous étiez là?
Bien, merci beaucoup. Merci. Ouais. Merci. On se téléphonera plus ultérieurement, Inch'Allah.
Avec plaisir.
Je suis en train de finir ma tournée tranquille.
Ouais, je vois, parce que tout à l'heure, je voulais pas me mettre comme ça, parce que j'étais dans une bagnole avec le machin et voilà.
Mais moi, j'ai assisté à l'essentiel.
Je rentrais de Casa tard et je voulais pas montrer. Donc, c'est pour ça que. Bon, mais c'est un très bon webinaire. Hein. C'est très bien passé. Hein. Tout le monde a.
Très bien. Bravo tout le monde. Et merci beaucoup.
Many thanks. Bye.